afternoons during this symposium. Dear participants, please allow me to acknowledge our guest of honor, who I believe may join us. We will check the connectivity. The always supportive and inspiring Professor Zebenay, our panelists, Dr. Mersha, Dalalem, Ali Delaynu, Mandela Birala, and our moderator, Dr. Mersha. I would also like to pass my gratitude to all who submitted their scholarly work for presentation, those who were accepted and those who weren't. I commend the scientific committee led by Dr. Teshager Mersha for their flawless and meticulous work till this day. My team at SPEAR were exceptional too and deserve my heartfelt appreciation. Dr. Brook, our IT guru, who is one of a kind, deserves my particular appreciation. Wishing us a great symposium. If Dr. Professor Zebenay joined us, she will give us an opening remark. If not, we will directly go to the panel session. Thank you very much.
As it has been described, our next session will be a panel discussion. So for this panel discussion, I will call our moderator, Dr. Zebenay, who is a medical doctor with OB/GYN specialty working in Ethiopia, with more than 30 years of clinical and public health program experience. He is currently the managing director of the Center for International Reproductive Health Training, South Africa, which is based in Addis Ababa, Ethiopia. He is responsible to oversee the integration and implementation of pre-service comprehensive abortion care and family planning training in the medical and midwifery education and OB/GYN residency programs in Ethiopia. Please, Dr. Mersha.
Thank you, Dr. Teshager. Welcome, everyone. Good afternoon to everyone who are here with us today in person, and greetings, depending on the time zone, to those of you who are following us virtually. Thank you for joining us. So today we'll have the first panel discussion of the second National Reproductive Health Symposium, organized by St. Paul Hospital Medical College and St. Paul Institute for Reproductive Health and Rights. So the topic for the panel session today would be the status of reproductive health and rights services in the wake of COVID-19. I believe it's a very important topic because it came at the opportune time, and I'm very thrilled and honored to be selected as moderator for these sessions. Today we have four amazing speakers with us here, and we are going to kind of come up with a new kind of style for this panel discussion. No speakers will be allowed to show their slides. They just speak their minds, and we'll give ample time for Q&A after presentation from each of the speakers. So, if I may ask all the speakers to come to the stage so that everyone can see you. Just to you as information, all of the speakers are from relevant walks of life, from policy, healthcare providers, representing professional societies, and most importantly, those the person coming from the private and NGO service outlets. So may I ask kindly the presenters on the stage so that I can introduce you very well. Thank you. So as you can see, we have like a very good gender balance on the speaker list. So may I ask to sit in every Dr. Nagar, you can come here. So it's going to be really a very good arrangement. Thank you. So it's always customary to start from the head, right? From the policy level and go down to the providers. Of course, with no particular order, it's all are like playing very important roles, starting from the grassroots level up to the policy level. But just to respect the customs, I would start introducing Dr. Mesarat. So I tried to look up literature about Dr. Mesarat, just to learn about how her experience is like. To be frank with you, it was a long list. And I should apologize to her for cutting, the list for just interest of time. And I'm going to read her brief bios as this one. So Dr. Mesarat, the one just sitting on the right next to the gentleman, Dr. Madele. She's a medical doctor with a specialization in pediatrics and child health. She is an alumna of the University of Gondar, where she worked and ascended up the academic ladder, starting from being a lecturer to the rank of assistant professorship. She had above 10 years of experience in academia, research, clinical care, community service, and various management positions. She demonstrated an amazing capacity in her leadership roles during her tenures as a medical director for Gondar University Comprehensive Specialized Hospital, as a chief of staff for the office of the minister in the Ministry of Health, currently as director for, directorate which oversees, almost all kinds of issues around, starting from the youth up to, I'd say, menopause, meaning reproductive, maternal, newborn, child, adolescent, and youth health and nutrition directorate of Ministry of Health. Dr. Mesarat is part of the African Nutrition Leaders Network and a member of Ethiopian Nutrition Board. She has published several peer-reviewed articles in reputable journals, both international and local, and currently sits in several boards as an advisory member. So today, she is with us to talk about, policy issues, particularly the response of Ministry of Health to the disease, this pandemic, hovering around the country. Thank you, Dr. Mesarat, for coming. So the second speaker will be Dr. Nagga. Dr. Nagga Tasfaw earned his Doctor of Medicine from Juma University and specialty certificate in obstetrics and gynecology from Addis Ababa University. Dr. Nagga worked at Juma University as an assistant professor of obstetrics and gynecology, during which time he held several positions of responsibility, including heads of Department of Obstetrics and Gynecology, Dean of Faculty of Medical Sciences. He worked as a clinical advisor at Gender Health Ethiopia and maternal and newborn health team leader at Jefaigo, Ethiopia. Currently, he is working as the Director of Quality and Clinical Services at Medistos International Ethiopia. He will highlight the post-COVID situations representing the private and NGO sexual and reproductive health services in the setting of COVID. Thank you for coming. So, the third speaker, a colleague, Dr. Mandela. He studied medicine at Zebenay University, received his specialty training in obstetrics and gynecology at Addis Ababa University, and subspecialty training in maternal fetal medicine from St. Paul Hospital, Millennium Medical College. He also obtained Masters in Public Health, and he is an associate professor with over 18 years of experience in the area of reproductive health. In the area of reproductive health, he is a member of Reproductive Health and Family Planning Technical Working Group, which is under Federal Ministry of Health. He is an honorary secretary of Ethiopian Society of Obstetrics and Gynecology and chair of RH sub-team and project here. He is a co-chair of the National Coalition on Comprehensive Abortion Care and contributor to the national guideline on RH and COVID. It's a very important role and relevant for today's session. He will focus mainly on the role of health professional associations to respond to COVID-induced challenges, taking the examples of ESOP. Dr. Maleda, welcome. Now, the famous Dr. Maled, again, her CV, just like the others, was like very long. Again, the time constraint allowed me only to talk the few parts of her journey in the past. So, Dr. Mahalet is an assistant professor and consultant obstetricians at Addis Ababa University, Department of Obstetrics and Gynecology. Since 2004, she has MSc in reproductive health and sexual rights. She is currently a fellow in reproductive endocrinology infertility program at Addis Ababa University. Dr. Mahalet has been an active clinical teacher for both medical students and residents in obstetrics and gynecology, and up until now published almost 16 articles in local and international journals. She has served at different administrative positions within the School of Medicine at Addis Ababa University. She has been a clinical director, head of obstetrics and gynecology in the same institution, a dean and CEO to the School of Medicine and Rambasa Specialized Hospital. She has been pivotal in the initiation of new training programs like Family Medicine Training Program at the School of Medicine, 3 fellowship programs at the Department of Obstetrics and Gynecology. She is the immediate past vice president of the Ethiopian Society of Obstetricians and Gynecologists and a founding member of Women Health Research Working Group at the College of Health Sciences at Addis Ababa University. She is currently active in various research undertakings in reproductive health. So today she is here to showcase responses of the healthcare providers to the COVID-19. Thank you, Dr. Mahalet, for coming. So let's start our session right now. So let's start with Dr. Mersha. Dr. Mersha, we know that when we heard about the news of COVID that happened in China and its mortality and its case volume was like rising up before the case was detected in Ethiopia, there was like uncertainty and really unexplained fear among the public. But when the first case was detected in Ethiopia back in March 2020, the fear that was built up from the news of other countries resulted in knee-jerk reaction among the population, among the healthcare providers, and most importantly, among the health managers. And that has significantly reduced the attention given to the existing services. And the salary service was not an exception to that. In fact, most reports show that the salary services are among the ones which are significantly and negatively affected by the reaction given to the COVID at all levels. So what was your reaction as a director for research, and what was your feeling like, when you heard the first case? Did you share the same fear that others were like expressing, and what was the measure your office was taking? Thank you.
Thank you very much. Good morning, good afternoon, good evening, everyone, wherever you are. It's really an honor to be in front of our colleagues and for those who are following up over the webinar. The pleasure to be on the comments and presenting the Wondimu Chirfa and the director for the Reproductive Health Care Provision are very efficient on this second national reproductive health day. And then coming back to the Teshager Mersha, the first case of COVID-19 has been reported in the end of March and which is, a global pandemic and it is a new experience for the last 100 years. And it's not only for Ethiopia, but also for the first of the country, the new experience and everybody will fine. But if you start with that, I'm leaving the most vulnerable groups, the mothers, children, and child, so that they enter into the group. They really demand super care, whichever the situation you are in. So the first action, when we have the management meeting, we have reported a COVID case, I started to discuss with excellencies. I was not like forced to get assigned in skills because most of my colleagues and most of the directors were reallocated to the county where they were tasked to lead the WASH program, the this communication program, logistic and the like. But I was not really interested to go to the agency because I was too still to going to the same essential functions and elements of critical, I could say. Because I can relate it's not emergent, it is an urgent decision demanding for my life. So I started to draft the guideline with my colleague, with my team. Then we did that within today. And I shared and I discussed briefly with today our state minister of federation. And then we started to also organize the other colleagues, other directors that the disease prevention and control, then they can program for WASH. So that we sit down as a director and we come up with a very short, very brief guideline, which is a guiding principle motive with sustaining the social function virtually and in line with the mitigation of COVID-19. So that was the story that we started. Then after that, we enriched the technical team, and then that draft that guideline has been endorsed. Even we didn't do too many times, maybe even I remember most of the countries that haven't because emergency will act to relieve. So that's the principle. We didn't get most of the partners. And then that was the principle that had a 15 pages by the principle in our height, and then we sent, and then we shared to the regional head. And then when you see the governance is structured in that post, it takes under the excellence of the state minister, and we are the steering team, and then down to the regional level, to the deputy regional heads, and the lead for the staff, and the party is the chief executive officer and the regional directors are from the lead. Down there are the community level, among the two heads in the office, one of it is responsible for the staff. So with this, we did that one, and then at least we try to mitigate this problem in a way that we have a new direction, and then we start a balanced communication on this, because if you remember, the communication was like diverted towards COVID-19, which looks like everybody getting known to when they are staying at home. But that was not the situation that we were in. And then we started to mitigate with the balanced communication, this communication, and then giving a new finance and starting coordination. And we also drafted the elements, components of KPI. Like we were assessing, we are also doing this one. We capture every week the mortality of maternal mortality, mortality report every week, and we also capture the case of severe malnutrition treated the care every disaggregated, and then the fourth element is we also capture the vaccine preventive outbreak. So not only capturing this data, but the response. We did the audit, we did a due analysis every week, and these are the components that I said. And the other two is we have also a Zoom platform every week. We coordinate the regional colleagues. We sit down over a virtual platform and then we discuss how many partners have been done and then why, and is there any analysis of any audit, what was the response in the lab. So that's the way that we were working on. And in addition to that, this essential element is not simply just, it's not only like executed by the preparing the guideline, but what really matters is the community. We also work very hard on the last mile delivery to community for this essential function. Most of the shipment has been dropped the shipment. We also, by adding the additional cost, we shifted from the sea shipment to air shipment, cargo cargo. So this is the way, and we try to figure out the shouldn't really have shortage, and we try to mitigate in a way that is done very, very milestone. So this is the principle, and then we have also seen the COVID case by that, and then we observed that there was an increased trend the first 2 months, and then after we revised that guiding principle into complaint. So how we can go beyond the arrangement and prevention program, and then how we can also include the other emergency critical services and all like mental service potential function. So we revised in April, now it's on. So this is the way that we are trying to mitigate the negative effect of COVID-19. Among others, reproductive and family planning services is one of the that. In a way that there are engaged principles to it. One, it's not like words to appoint a lady or a female every month to collect her from, for her medication for family planning, I can say. So for that reason, we also made a forum, including the presence of the virtual presence of Her Excellency Madam President, if you remember, we did a great advocacy for administrative disease. And then very recently also we had a high-level forum for a world contraceptive day, including bringing the highest political leaders. And one example I would say, the Somali regional president, the Excellency from Tokyo also was also just of the platform. I can say our excellency as the minister are really committed to echo for sustainability, scaling this essential function. It's very, very interesting to communicate from what. Thank you very much for having me.
Definitely, we'll come back to you later on with a number of questions from this room and I'm sure virtually as well, right? So thank you. Just looking at the situation from policy point of view, your response was really amazing in the form of developing strategy and policy, and also implementing a strong M&A system so that indicators are coming up in efficient manner and the close follow-up on them. But that should be interpreted at service outlets, right? Because ultimately, all what we do at policy level, at regional level, whatsoever, should be interpreted at service outlet level. So how likely was a single mom, a woman, have like easy access to those services, particularly in the wake of this COVID-19. So let me start from the private outlet. So the government is supporting everything, as Dr. Masara said, and how was the impact like in the private outlets, particularly MSI, given that MSI took or takes, the lion's share of SRA services in the private domain. How was it like? And what was your response to that, Dr. Naka?
Thank you, Dr. Mangistu, and thank you all for giving this opportunity to talk on our experience in mitigating COVID and provision of SRA services. Yes, our responsibilities were probably two. One is the COVID prevention, and the other is ensuring continuation of SRA service. We had program delivery responsibility, supporting some private facilities and some public facilities, as well as service provision responsibility because we have clinics. So at the moment we knew COVID is in our country, March 13, 2020. So we realized that there is already a panic everywhere. So what we did was, as a management, to sat down and we discussed, started dividing a COVID adaptation plan. So some of these interventions were, one was adapt some guide, because if you remember that time there was a lot of misinformation to providers, to the public, and so on. So we have to make sure that our providers and staffs are receiving reliable information, like the ones from Australians, WHO, and so on. So we want to make sure that they are receiving the right information. So we developed a brief guide to all staffs and providers. That was one. The other thing was we want to ensure that we have the right resources. If you remember that time, having PPE in country was a shortage or very expensive. We have to import some from abroad and some from local. So for that, we need to secure resources. So we reached donors, and also we try to allocate some resources to ensure that we have the right PPEs. The other thing was, again, orienting staffs, providers, everyone, starting from cleaners, providers, and staffs in general. So we did that orientation both on the job as well as virtual. So we did this. We secured the PPEs. Then we set triage the facilities that we service that we provide and also that we support. So with this triage, we ensure that every client, attendant, provider is checked his temperature and also asked those questions. You remember the time common symptoms before entering the bed. We set up also hand hygiene facilities at the entry, so that was ensuring that everyone is washing before entry. Then we have to make also some rearrangement in the waiting areas, so as to make the distancing. We have to ask clients to come only with one attendant, could minimize crowding, and we have to also ensure everyone is wearing masks. So we ensure everyone coming to the facility is wearing masks, and the providers, everyone. And the other important thing was ensuring the continuum of care. We have a contact center whereby that time there was a panic everywhere, so everyone was previously that contact center was set up to respond to SRS questions. But in fact, most of the questions coming were related to COVID. So we oriented them, so they answered these questions. They referred to the National Contact Center also and the COVID Center. So we did this, and because that time, because again the panic in the public, the client flow decreased at the beginning. So we advertised that we are open with all the COVID precautions. So that was also very instrumental, because that time clients were considering that some of the public facilities, because they were providing converting to COVID treatment center, they were thinking that they will not provide SRA service. So there was an impact to our facility. So we also ensure that they are getting the right service by mentioning that we are open with all COVID preventive precautions. So we try to mitigate with This because both are important. COVID prevention is important, as well as SRS is important, because if there is unplanned pregnancy, we know the consequences of it. If there is unsafe abortion, we know the consequences, and if there is no skilled attendance at delivery, there is those consequences. So we ensure that both are balanced and available. Thank you.
Thank you, Dr. Naga. Obviously, again, I will come back to you just to show us the trajectory and how did the policy backup from the Ministry of Health help out in terms of keeping the volume and the quality of services in MSI clinics later on. Dr. Mari, again, as OBGYN and as experienced practitioner, clinical practitioners in Blackline, how did you perceive the shock? Because obviously we said the news, created a lot of mixed feelings among healthcare professionals, and how did that shock level, impact the service outlets in Blackline?
Thank you very much. Good afternoon to you all, and good morning for everybody around, and good evening to audiences online. I'm thrilled to be here and to be part of this important symposium. And thank you for the organizing committee to be part of this honorable panelists. So thank you for the question, Dr. Mensu. I think I remember when we had the first Japanese case, the time was almost 3 p.m. Friday. We are almost winding up our management session, the regular teaching management session. And it was a text that came in. And we identified the first imported case. And the session literally stopped because everybody saw it. And I remember one of my residents, he said, COVID is here. He said, COVID is here. Yes, we know. The shock was not beyond our imagination, because already many informations were coming. The distort was increasing in other cases, as well as the case detection, the limitation in diagnostics were there, and the information, especially with sexual and reproductive health services, they were limited during that time. So we were shocked that it is coming, but I think the most important thing was, what should we do? Because by that time the ministry had already set an organogram for mitigating strategies at each level, from the national, at the federal, regional, and at the hospital. So by that time we were already ready, setting up the emergency operation center of the College of Health Science, and through that we were ready to make our service open. Because from then on, with the protective measures that are being taken by the government, we knew that some of the centers would be COVID treatment centers. So we had almost 39 catchment health centers for Blackline, and we knew if half of them would convert to such a care, the service burden would increase. So we arranged our service to be to offer the necessary human health care appropriate to our level. So unlike the private setting, we expected the case numbers to increase because we were designated then at the beginning as a non-COVID care centers. But as time passes, things become very confusing, because unlike our expectation, actually the number of patients initially dropped down significantly. Like forget the family planning, comprehensive abortion care, and so on. But even antenatal care, we lost 70% of our follow-up in the beginning, 70%. So we were very much shocked, and we need to talk to our catchment health center to tell them what is wrong in the first place. So where are they delivering? I mean, if 70% of our referred antenatal care are not coming, where are they delivering? So I mean, they must have done many things, I am sure. And the cases from other like regional hospitals were still planning to be COVID health centers. And so continuous efforts from the region and the federal government, Ministry of Health, the case started to come. But what was thrilling was there were two things that had made the significant work. Number one, at the catchment care center, the health providers, even the sexual and reproductive health workforce, were being employed to be a COVID, like the COVID card. The other thing is there was huge, as you all remember, huge public anxiety, and almost everybody has limited itself from coming to the facility because the facilities were taken as a place where we can acquire the infection. So, especially Blackline Hospital, being people assume that this is a high-risk hospital. So, through many communications and diligent efforts from different stakeholders, then the woman started to come up. Then the second problem came. Then our caseload started to increase. Then we have to set in the preventive strategy, like appointments, especially for obstetric care. We have to schedule appointments. Distancing schedule was not possible to our situation because they are referred cases. They needed management within 2 to 3 weeks, maximum 1 month. So we could not prolong our schedule more than 2 weeks. And the gynecology care and so on, that we changed it completely into phone clinic to get a space for the obstetric care. So both interventions had their own toll. When we spaced the schedule, patient could not come to the scheduled call on time. So spacing was literally impossible. So gathering of mothers and their relatives was visible for us. So we could not put in place the social distancing that's recommended by the clients for the public. The other thing was that the phone clinic we thought would offer family planning consultations, continuum of care, abortion-related services, and other gynecologic services could not, it worked initially, but could not materialize because 2 problems. Number one, for every physician, you have to use your own phone to call the patient. So you can call them one day, like what I did was when I called them to tell them like 3 or 4 patients, I tell them while I called what I wanted them, it was okay. But they will call you in the middle of the night and they say that they need a consultation, So it really violated your privacy and you could not give any consult to them at that time. So it really did not work out. It continued for some time, but it did not work out. So what we saw in the first and in the continuum of COVID care was service re-engineering is a must. I mean, if we cannot, with the decreasing number of health professionals, with the flow of the case flow and the diversity and the type of sexual reproductive health services, I think we need to come up now when it is integrated and later, but we need to be engineered. So that was what we had at the beginning. Thank you.
You are a very good shock observance. So thank you, Dr. Mahale. So Dr. Mahale, again, I know you have like presence everywhere, particularly in managing COVID-related challenges, but I would like to get focused on the roles of health professional associations, taking the examples of how we respond to the challenges regarding this COVID-19. At the start, the anxiety, the uncertainty, all the confusion created unexplained emotion among healthcare providers. And you, representing ISOC and representing many numbers of health professionals, particularly OB/GYNs. So what was your role in terms of appeasing that emotion among the health professionals and to help them keep their composure and get focused on the existing health service activity?
Okay, thank you, Dr. Nus. So I think most of the things has been already said, so we'll be focusing on the remaining issues. So in March, as you remember, it was like a tsunami when the information that the first case of Teshager came out. Everybody was in panic, and as you have said earlier, it was a knee-jerk reaction, and there was also overflow of information. There was misinformation and overflow of information, and everybody was not clear about what to do. So ISO was on that stake, and we had 2 responsibilities. We represent professionals, but at the same time, our stakeholders are also there. the service seekers, particularly the reproductive service seekers. So at that time, the major correction was interruption of the service for all ambulance and so on. So in most of the places, including Addis and particularly outside Addis Ababa, most places have interrupted giving even emergency services, leave alone the family planning and other abortion services. Emergency services has been interrupted, and that report was coming to us, and even bad reports like some kind of morbidities and so on has been coming. So we were in a state to do something. So what we did was based on the request coming, which came from the Ministry of Health. We developed or established an ad hoc committee or task force which develops a kind of primary guideline or protocol or handbook, which can help the healthcare professionals to work in the presence of COVID. And then we were engaged in that activity, and we developed within a week or probably 10 days the first draft of the protocol on the management of COVID during COVID pandemic management of SRH services, and that was submitted for the Ministry of Health. And the other thing was convincing the healthcare providers by every available means like social media and so on that the service has to be continued. But there was a growing question that the PPEs or the personal protective equipment were not also available, and we had to lobby the Ministry of Health or every other partner to give these PPEs for the care providers so that the service would be continued. And also we were, like providing the information, the publications, and some kind of research findings coming from outside, like from Europe at that time. Most of the data were coming from the US and Italy. So we were providing those information to our members. So with that, we continued. And later on, after some 1 month in this one, we managed to get the service to be restarted in at least most of the places, along with the support of the Ministry of Health. And afterwards, what we did was we established or we started a kind of webinar, continuous webinar, which is broadcasted through Zoom to our members in providing credible information on the management of COVID and prevention of COVID. And as Dr. Marif has said, one of the important things was the prevention of intra-hospital or nosocomial transmission of COVID. So we developed some kind of protocol, how we can re-engineer the service during the time of COVID and so on. So those things have been given. Importantly, when we were doing this and our staffs were motivated, and later on the COVID centers were opened, at least in Addis Ababa, and we lobbied and convinced our staffs, our members, to go and work in the COVID centers. Later on, there was a growing stigma against the providers. In fact, the stigma was against all the providers, but particularly it was highly reflected on our members, on professionals. So as you remember, there were some people who say that this was related to some kind of, safe abortion service delivery and so on like that. And people in general has been also being stigmatized and so on. So to fight that, ESOC particularly had created some kind of partnership with other reproductive members, organizations, and we did a lot of work in that regard to combat that kind of stigma, growing stigma. So if I remember, for example, at St. Paul, during the time of the first case report and when every hospital was opening a COVID pre-triaging units, the first tent and pre-triaging houses has been built just in front of our family planning, and it was already closed. So those kind of stigmas in this one has been combated, and we managed to restart the service again. So that was how we did. And apart from this, we motivated our staff to do research with regard to COVID, and we had some few number of research undertakings in different parts of the country. And that was what we did. Probably, if there are other questions, I will be happy later.
Okay. Thank you, Dr. Maleda. So I came here today just having looked at the data in an attempt to see the trajectory. Just after the first event was announced in Ethiopia and the few months after one. So I would like to ask Dr. Naka, because Dr. Masarat has already elaborated on the policy backup and all the responses from the government side to restore and to keep the momentum of the service provision. So how was the trajectory like? Obviously the national data shows for a few months starting from March, there was like a tendency to decline, both in terms of service volume and quality. Then around July, June, it starts to, going up. So how was it like in private setup? Looking at the trajectory. So in a minute, can you just, give us information?
Yeah. Thank you very much. I think the trajectory we all know, COVID is still there and likely also to continue for a certain period, 2 years. So we have hopes that we will be having the COVID vaccine, but certainly that will also take time. So trajectory, as we know, if you see the positive rate
in terms of service volume and
so that's the COVID. The service volume, yes, during the panic there was decline. Immediately, clients decreased coming. Later on, because of as I mentioned earlier, we informed that we are open, and Ministry of Health then gave attention from the higher level as well. So there was then clients start coming. We adapted our service also to the increased number of cases by appointments and rearranging the facility. And also we monitored literally at the beginning for 1 2 months, we had a daily discussion on situation. Even now, we are having a weekly monitoring management. We are monitoring at the management level how it's going on. So I think this has to continue because we need to adapt. We need to adapt to the new normal. Whether we like it or not, COVID is there and will continue for some time. So we need to adapt. These services are very essential. We need them, and COVID is still with us. So we need to adhere to the recommendations while still providing the service. Thank you.
Okay, thank you. So do you want? Yeah, please. In a minute.
In a minute, because I have observed, maybe many of you have observed in your clinical practice, family planning dropout has increased dropouts. People taking, especially office workers, housewives, and so on, they are demanding to stop this family planning because they are staying home and they are taking this to have kids. Okay, so I think those conditions should be taken into consideration when we are projecting, especially the obstetric service. The burden is not going to go away, even if COVID goes away today. The burden of obstetric emergencies, obstetric care, and newborn care is going to stay with us for at least 1 year. So I think that pattern is taking to be told.
Okay, so in 1 minute, probably one phenomenon that happened along the course of our effort to combat COVID-19 is, as much as the COVID-19 brought a gruesome phenomena in our lives, of course, it has also opened rooms for opposition groups, particularly those groups who were struggling to run a smear campaign against some components of reproductives, particularly around abortion care. So I think it's not fair not to give a few minutes or probably a minute to talk about that because it was a new phenomenon. It is not new actually, but it's a kind of uncovering long-standing hidden problems. But the opportunity created by COVID-19 uncovered those factors and kind of impacted negatively our service load and also quality of service. And as Manada said, that some of our colleagues were like discriminated, and some of them were like shying away from providing the services. So would that be okay if one of you, shed light on that, how the professional societies or Ministry of Health or service outlets were responding to such facts during this course? Any one of you?
Okay, as I have already stated, it was a kind of problem, like what it was in America. So when everybody was struggling to work during the terms of this pandemic, where there is no remedy, most information is not known and so on, where people were, particular professionals were working, risking their lives and so on, in the absence of adequate supplies. So unexpectedly, this kind of stigma, which was targeted against the safe abortion providers, have emerged. In fact, it was there underground, but it surfaced out, visible and even at once post-televised. So that had created an immense reaction from the public and unexpected additional burden on the healthcare professionals who are working on the SRH. So we, particularly the healthcare professionals, I'm talking about this sort, had to react, and then we tried to galvanize our stakeholders who are working in the NGO and so on. So we created some kind of working group or group kind of collaboration. So with that, we had very frequent contact, Zoom meeting and so on. So we worked a lot in that regard to bring back that tone of stigma. And it is not still completely abated, but I think there was some struggle and it is going well. So this is probably a continuing problem, and we need to struggle, and probably one of the emerging problems. I don't know what will it happen once Trump.
Yeah, obviously it is the elephant in the room.
Yeah,
and it's been like a simmering problem, and you know, as RH community, that is something that we are going to be challenged in the time to come. So with this, let me divert the attention, the spotlight from the stage to the audience. So any question? I have tried to collect questions through papers, but if anyone from this group wants to ask any question for the speakers, I'm glad to give you the time. Dr. Allen.
My question goes to Dr. Mersha.
Can you introduce yourself?
Yeah, okay. I'm Dr. Allen. So, as we all remember, COVID-19 outbreak from the first phase was taken in March 30, and Dr. Lia was assigned as head of ministry in March 2. So she was assigned to March 2, and on the next day, the first phase was so you told us that you didn't lose the focus, you focused on networking, but with a new administration in place, and because of the outbreak almost at the same time, how was the reaction from the administration?
Thank you. Dr. Brahano?
I think COVID will stay with us for some time, and as I did some difficult meetings recently, I see that the world is going on telemedicine and teleconsultations as a mitigating strategy to avoid all this drawback that was mentioned. So, what is the direction now concerning telehealth, telemedicine, and teleconsultation to avoid some of the gaps that are identified? Thank you.
Any woman colleague? I will give a chance. I'll give you. Anyone from sisters? Okay, I mean from women. Just to kind of keep the gender balance again from the audience of them. Anyone? Okay. If not, please give it to the other. Yeah.
Okay, thank you very much, Dr. all the speakers for this timely issue, and I would like to congratulate again for bringing this opportunity. So I'm Altoga from Resource International. I have a couple of questions. The first one goes to Dr. Mersha. I think I have a feeling that this COVID has brought some kind of an opportunity in terms of testing ourselves, whether we are in a resilient health program or not. So from that point of view, I think we have proved that condition. Our healthcare system really responded well to this pandemic. But my question directly to how our healthcare policy is strong enough in terms of addressing the same kind of crisis might happen in the future. So how is the resilient enough? Have we got a chance to learn from the COVID and prepare ourselves or position ourselves to respond to any kind of crisis that might happen in the future? That might be the first one. The second one might be to Dr. Malada. I think the provider stigma is one of the critical issues. I'm trying to relate the provider stigma attached to COVID vis-a-vis the provider stigma what has happened at the onset of HIV/AIDS. So can we say that the way the message was conveyed through different means that attributed to the provider stigma because of this COVID issue? So this is the two things. And again, is there anything that the ISO might propose, any provider stigma mitigation strategy that should be happening?
Good, thank you. That's all. Okay. Okay. Jamal,
Thank you. I would like also to.
I would appreciate if you make your questions very brief.
Good. I would like also to acknowledge the speakers, and I'm very much also amazed by some of the experiences the speakers mentioned. I have just two questions. One is in terms of adaptation to such emergencies. Dr. Mersha has mentioned that the ministry has worked on a lot of interventions to sustain essential services, including the product care services. But like in terms of since like the new normal and COVID is going to continue, what we have learned and what we have put in place in terms of new service delivery modalities. I know there has been efforts to come up with self-care guideline, but where are we and what we have learned in terms of updating services, including self-care. And the second is I didn't hear any one of the speakers mentioning about some of the opposition voices against reproductive health and how that has affected the service provision and ministries' policies.
I think this question was partly answered by Leda, but they can make it pronounce it. So anyone? Okay. Dr. Abraham first, then make it as short as possible, please. And
Thank you for the panel for your explanation. So my question goes to Dr. Mersha. So how early prepared was the district in allocating the resources before development of the guidelines? Because in the early pandemic, luckily I think we were able to prepare the COVID-19 treatment and infection prevention guideline earlier, but we are having difficulty in accessing the resource while we are to work with that guideline. So how the ministry prepared to distribute the resources there?
thank you. Dr. Balk.
Thank you very much. Just two questions, and if you can respond to it. One thing that probably affected is the supply chain. So how did that affect the SRH services in the country, and how was it tackled? The second one is how are you mobilizing the different stakeholders working on SRH in redirecting resources to combat the different challenges that healthcare providers are facing in protecting themselves from COVID and in continuing to deliver the services? Thank you.
Thank you, Dr. Bal. So I have just collected one question. It could be like any one of you. I think it's a generic question. It says, what opportunity COVID, brought about for the SRH services? So what opportunity do you see, that COVID, came up with? So these are the questions. I think in the order of number of questions, it would be good if you start the response from Dr. Mersha. Many questions here. Over to you. So.
Thank you very much for questions and comments. I can start from the first question. response. I have partly responded during the beginning of my reflection. I could say, Excellency Minister Lee, I was working as a state minister before, and then it was not really a new appointment, just change of position. Otherwise, she was in charge for the program, and then she knows the details of the ministry and then the details for a year. And she has also previous experience. And then we didn't get panicked when she was assigned. And then immediately after a day, and we have learned that COVID has been reported, the first case has been reported, and then I don't think that has really impacted us because it's not a single person who is really leading the system. It's what really matters is the system. We have a very good grounded system in the Ministry. So wherever the DMC is here or not, the system is functioning. But what really demands is the highest level policy people will, person will give us a due guidance, and she was there for almost 2 months, assigned, delegated, and then she was just running that activity as well. I don't think that really impacted a lot. The digital health, I think this will be an excellent innovation where the ministry will definitely look into the system revision, because COVID is giving us an opportunity to look into our health system, how we can really fix it, because we have to prepare for, we need to prepare for the second type of emergency, so we need to get prepared and we need to have innovation. One of the innovation modality will be to use the digital platform. And the third one is for the health policy guidance, that I think I can say this is the right time where the government is working on the 10-year development plan, and aside of that, the Ministry is working on the second version of HSTP2. And then I can say one of the highest, the pillar is the emergency preparedness and response. Now this is the high time which has been included. You remember last week we had the annual review meeting for 2012 Ethiopian fiscal performance for the ministry. So Mr. Leah has also presented the endorsed HSTP2. It's already signed and endorsed. One of the pillars in it is the emergency preparedness and response for us to lead us to resilient health system as a part of that. And the other thing is the health delivery, health system, health service delivery modality. I tried to mention, we did try to respond in different ways, like using a telephone conversation to follow up most of the clients that have been started in a distance that doesn't work for the rural area, where some of it, one of the deliverable might be certificate guideline and development. I think that is undergoing. We will finish that one, and this will be one of the outputs which we learned from COVID-19 for how we can go for service modality, which I can say will be also one of the innovations. Related with the opposition, we try to mitigate in a way that it's not with reactive response, but we need to be, as a government stake, we need to be proactive, and we have to also expect it might happen anytime, but we have to be always proactive, to be in front page, to give the right information for the right person at the right time, because the people should trust us, trust the government, so that the government's responsibility is to be proactive. It shouldn't be reactive for any opposition. So this is our assignment, and then by coordinating all the efforts of the partners, we certainly respond for such a way. And perhaps for the resource, I can say one of the modalities that we were using was coordinating the efforts of the stakeholders, civil society organizations, partners, donors, groups, and from the academia. We try to coordinate everyone, and we were also looking all the resources, how much resources are allocated, for which region, for which facility. We were coordinating that one. That's why we try to protect our healthcare providers and supporting staff, so do for our clients and the community at large, so that without resources, it's very hard to mitigate this COVID, to protect and respond for COVID-19 infection as well. So we coordinate efficiently. I can say we will keep going to efficiently coordinate all stakeholders as the government. And finally, for the supply chain, I can say this is also the pillar for the health system. We were also proactive enough to mitigate this problem, you know, where it starts from the forecasting, the right forecasting and placement of procurement, and keeping a funding, and then like, you know, all the systems, because the family planning or reproductive is all commodities. I can already say it is, we procure abroad with fingers foreign currency, so that we were proactive enough to make this available. I don't think there was a shortage during COVID-19, unless it is artificial, because we place for a year and then we try to even do the last mile delivery. And I also appreciate the effort of the developmental partners, where they really supported us to reach to the last milestone. In general, information is also really matters. Dr. Mangstu has mentioned at the very beginning the trend analysis. In addition with the emergency, the FAME report every week, we were also looking into the trend analysis from the data institute. We have observed that there was a sudden declining of all the service uptake during the months of March and April, but it starts to fire as of May. So we also check on the annual performance for the 2012. Almost, I can say, half of it were during COVID-19 pandemic. And then, general speaking, it's not like hugely affected as it was forecasted, because the government stakeholders take everyone. And using this platform, I would like to recognize and appreciate the one who sincerely extend my appreciation for all stakeholders for really supporting the government effort for reaching our milestone, I can say, in the face of COVID-19. We certainly keep going to reach our mothers before the children and adults and youth. I mean, to meet our goal. Thank you very much for this time. I also appreciate the same for my day.
Thank you. Thank you so much. So, this is Madhada. So, Madhada, you have like few questions? Yeah.
So, I have two questions. The first one is regarding the provider stigma. Yes, provider stigma is it's a kind of ebbs and flow kind of problem. It's not only related to COVID, but related to HIV and safe abortion and so on. So every time these kind of things happen, the providers and the professionals are affected. So ISHOC is developing a new kind of stigma mitigating, provider stigma mitigating platform, or kind of new kind of scheme. And probably in the near future, in a couple of months, we will be starting that kind of training scheme. And once we test it, we will be sharing that idea for other stakeholders. So we will be mitigating provider stigma. So the opportunity obtained from COVID, and it has been said time and again by different scenarios. But to mention, I mean, we have obtained a significant behavioral change in terms of infection prevention compliance by our providers and professionals. So everybody is sticking into IP protocols. So this is a huge gain. And also the use of ICT in terms of education and service delivery, virtual clinics, teleclinics, and so on. These are expanding, and probably that would be the future. Okay, the direction of the future is like for offloading the service. Telehealth and the virtual clinics will be established. So those kind of things are some of the approaches obtained from this COVID.
Thank you. So I will give the last minute splitting between you. 30 seconds. Okay.
Thank you, sir. Thank you very much. So just to reflect on two points. One is opportunities mentioned. Yes, as Dr. Maled mentioned, one of the great opportunities of COVID is our adherence to infection prevention. So we have seen that providers are highly adherent to IP, high better than the previous time. So that's one. The other is innovations, especially like use of technologies. Such meetings we happen before a lot of people collect. So remotely supporting virtual trainings, virtual meetings, virtual assessments. We are able to conduct virtually how providers are adhering to infection prevention. So virtual assessments, and another opportunity is this is again a time to raise the question to empower women and consider also self-care in some of the services. So these are opportunities that we can think of as innovations. The other just on the opposition or against SRH service. Yeah, this has been before and it's still there. Usually these oppositions are against, mostly against safe abortion, sometimes against family planning. So thinking of this is as a result, partly as a result of people don't think of the consequence of unsafe abortion and the consequence of unwanted pregnancy. In collaboration with partner organizations, we have developed a video story showing the previous experience during the era of where unsafe abortion has been prevalent in our country. So I think we will share you this video from the experts, senior OBGYNs who have faced those consequences. So I think that will help people to understand what the consequence of the other lack of service would mean. So that's very important, and always people should consider in the client's shoes. So that's, I think, very important for all of us to consider. Thank you.
Thank you, Dr. Aga.
I would just like to touch upon the health system resilience. You know, the world has faced many viral diseases, okay? But I think we have failed as a country to learn from that. Okay? So COVID creates an opportunity, I think, to see our health system and to rebuild it again so that we respond to any other emergency devastations like COVID. So it falls on the training institutions, policy organizations, and even health provider associations that we need to work towards resilient health care system, which COVID has opened as an opportunity. And we should not forget that we have also an agenda to meet in 2030, the workforce agenda, okay? And Africa, especially the sub-Saharan Africa, is going to need more health professionals, highly skilled, competent, and flexible to address any emergency and emerging health risks. SRH will be one of the conditions. So I think we should be ready for expanding our services and innovative services like what has been seen, so that we have a resilient healthcare system.
Ladies and gentlemen, colleagues, we have to be used to the next new normal, especially in the domain of SRH. And this will take us to the end of this session. And I would like to express my appreciation and gratitude to these wonderful speakers. Thank you for your time and sharing your experiences. And also to you, the audience, for the active participation. Thank you so much.
welcome again. So this will bring us to our next session. So our next session will be an oral presentation. We will have 4 oral presentations, and we will have 2 at first, followed by discussion, and then the rest 2 after that. So I will invite our moderator for this oral session. So our first moderator is Dr. Unet Gabrahana. She's an assistant professor of public health and reproductive health at the Public Health Department of St. Paul Hospital Millennium Medical College. She's an academician, researcher, and advocate of reproductive justice and equality. She has participated in several local and international researches, and she has contributed enormously to the scientific community. Please, Dr. Unet. Our second moderator is Dr. Brahanu Kabada. Brahanu Kabada is an obstetrician and gynecologist and fetal maternal medicine subspecialist with several years of clinical and research experience. He is also an editorial member of ISOG and an institutional review board at Ekati 12 Hospital. Please, Dr. Brahanu. So the first 2 sessions will be led by Dr. Unet. So Dr. Unet will invite the participants, the presenters.
Good afternoon, everyone. Out of the 4 presentations, we will have the 2 and followed by discussion. So I will invite the first 2 presenters, Mr. Zebenay Workneh and Dr. Delaynu Bekele. Mr. Zebenay Workneh is from nursing department at St. Paul Hospital Millennium Medical College. His study is about depression and associated factors among healthcare providers within the gynae department. He has included both caregivers, researchers, and academicians from the department, and we will hear the results, the prevalence of depression and the associated factors. The second presentation will be by Dr. Delaynu Bekele. It's about what happened during the panic period of COVID-19 epidemic. In the first period of the COVID epidemic, he will tell us what happens to the service delivery of family planning, maternal health, child health, and newborn health. And his study is among clients of St. Paul Hospital and related catchment areas of the hospital. So Mr. Zebenay will give us the first presentation.
Good afternoon, everyone. So I'm Zebenay from St. Paul Millennium Medical College, and I will present depression and associated factor among healthcare providers in the gynae department. So I will present on behalf of other authors. There are more than 7 authors for this study. So this is a primary study that is conducted in St. Paul Hospital Millennium Medical College, and it is part of a larger project which was conducted, which was done about the psychosocial impact of COVID among frontline healthcare providers. This is the presentation outline. So as you see from the slide, coronavirus has been increasing from its first inception or first origination in Wuhan, China in December. So on November 5, more than around 50 million confirmed cases has been confirmed, and there are more than 1 million deaths. In Ethiopia, it's around 100,000. It's clear that the pandemic has serious psychosocial or psychological impact in the public as well as in the care provider. Of course, the problem is higher in the care provider because they are directly involved in the care support and other activities, so they will have direct and indirect involvement in the. So the risk is very high or relatively high among the frontline healthcare providers. So even the clinical decision making has been affected because of fear of contact of the virus. So this coronavirus has serious psychosocial impact in the healthcare providers. So the primary objective or the objective of this study was to determine the magnitude of depression and associated factors among those healthcare providers in the gynae units. So the study was conducted in this period, and it was conducted in St. Paul Hospital, Millennium Medical College. I think we all are familiar with our responsibilities in St. Paul. Our responsibilities, or the responsibilities of St. Paul, are clinical service, including the COVID care and treatment, which is currently being implemented in the institution, teaching, as well as research and community services. So these are some of the responsibilities. So the study was a cross-sectional study, and we did among randomly selected hospital staffs who are directly or indirectly involved in the maternal cares. So those questionnaires which were incomplete were excluded from the final analysis. So finally, a total of 133 healthcare providers were involved, including nurses, midwives, and physicians. And we use a structured self-administered questionnaire to collect the data. And the tool that was used to diagnose depression was HADS. HADS diagnosed both anxiety and depression. It has 7 components. For depression, as it is mentioned there, so the scores were summed up, and those who scored greater than 8, greater than or equal to, were diagnosed to have depression, and the data entry, cleaning, and coding was done by using the 7th version, that means IPINFO7 software. And finally, the analysis was descriptive, and analytic analysis were done by using the SPSS software, which is the version 25. And factors were computed by using both bivariable and multivariable logistic regression, and the measures of association was computed using the odds ratio. So ethical clearance was obtained from the institutional review board of St. Paul Hospital, Millennium Medical College, and verbal consent was obtained from the study subjects, as well as we explain as if the participation to the study was voluntary, and the information that we obtained was kept confidential and anonymous. So when I come to the result and discussion, coming to the socio-demographic characteristics of our respondents, majority were physicians, midwives, followed by nurses, and the median age of respondents was 27 years. The majority of the subjects were under the age of 26 up to 30 years, and the majority of our respondents were males. So when I come to the working unit or the working area, the majority of the respondents were from labor delivery, and followed by the emergency, that means the gynae emergency. So this is the magnitude of depression that was assessed by using the HADS scale. Around 64.7% of our study subjects were diagnosed to have a depression, or they were diagnosed to have some depressive symptoms. So when we compare our finding to other studies which were conducted prior to our study, our study finding, that means the magnitude of depression in our study area, was relatively lower than other study findings. Different study findings in China, as you see, there are different study findings. That means most of them are lower than our study findings, like in Pakistan, Turkey, Italy, Bangladesh. As it is displayed in the slide, most of our study finding is highly lower than other study, highly greater than other study findings, but our study finding is relatively lower than the study finding in Turkey, which was conducted among the frontline healthcare providers. So the possible justification for the discrepancy might be because of different sample size. As you see, our sample is around 133. So there might, the sample may be the cause for the variation. The other, the study setting. The study setting. Our study was conducted in the gynae units, but other studies they were included in different clinical setups. The other is study population. Our study was conducted among the maternal care providers, but other studies they were also conducted among other study or other clinical units or other study subjects. The other is assessment tools. In our study we use the HADS scale, but most of these studies they use the patient health questionnaire scale. So the fact when I come to the factors, we use both bivariable and multivariable logistic regression analysis. So in bivariable logistic regression analysis, the marital status, profession, workplace, being trained about COVID treatment, current treatment, having social support, emotional response, different scales of or ranges of emotional or degrees of emotional response. They were eligible for multivariable logistic regression analysis. So in bivariable analysis, when the odds ratio or when the p-value is less than or equal to 0.5, we directly export it to the multivariable logistic regression. So our first factor that independently predicts the outcome variable was being trained about COVID care and treatment. This is so being trained about COVID care and treatment increases the likelihood of being depressed by three times as you see. So our justification may be because of the duration of the training, the duration of training about psychosocial support, special psychosocial support. There is a COVID training. The training usually takes about 4 days, and the psychosocial first year training it took not more than 30 minutes. I've seen it, the training package of the Ethiopian health system. So probably that may be the reason behind, because this is a paradox. The other is having good and intermediate social support were found to be protective from depression as compared to those who have the poor social support. So this may be because social support may avoid some feeling of loneliness, isolation, as you see, one of the principle or one of the controlling mechanism of COVID is social distancing. So when there is social distancing, there might be feeling of loneliness, things like that. So social support, it improves the quality of life, as it has been seen in some study findings. The other is having negative emotional response to stress. When there is stress, there might be positive or negative emotional response for stress. So those who have negative emotional response to stress were 3 times more likely to be depressed as compared to those who have a positive emotional response for stress. So when there is poor emotional response, there might be some problems that will follow, like burnout. Even some clinicians in abroad, they terminate even their job because of poor coping of stress and other problems. So in conclusion, depression among frontline health workers is considerably high, as you have seen, as we compare from other findings. And training should be, it will be better if the training focus on psychosocial support, especially psychosocial support should be given a greater emphasis. So the other thing, post-training evaluation, especially in our setup, there is poor post-training evaluation. That means mentorship of the effectiveness of the training should be it may have some implications. The other is training should always focus on altruism. That means the value, the moral value of we clinicians during the pandemics. The other is it may be better if we assign some psychosocial supporters in the service areas, in the clinical units. So these are some of our findings. We are really grateful for our study subjects probably some of you may be the study subjects. The institution, St. Paul Hospital Millennium Medical College, and St. Paul Institute for Reproductive Health Rights. Thank you very much. I'm done.
Thank you, Mr. Zebenay. Dr. Delaynu for the second presentation.
Okay. Good afternoon again. So the topic of my presentation is as displayed panic phase of the pandemic, the impact of early COVID-19 on the reproductive health service uptake. As mentioned in the morning, the panel discussion, and as all of you know, in the initial, when the first case of COVID-19 was detected, there was a great panic among the healthcare providers and other community, and there was an observation and a concern that RMNC service uptake is decreased significantly. So what we did was immediately after 2 months of the first case was detected, we wanted to objectively see the extent of the decrement in these RMNC services at St. Paul's and some selected catchment health centers. So basically, we have what we have done is assessing the cervix statistics. So this is team members of this study, and I'm presenting on behalf of them. Next slide. So this will be the outline of my presentation. And so as an introductory remarks, as you know, the emergence of COVID-19 pandemic has strained the health system of almost all countries, including the developed and the developing countries, but its impact is obviously more pronounced in developing countries like ours. And past experience from similar outbreaks has shown that when the health system is overwhelmed by such kind of pandemics, mortality and severe morbidity from preventable and treatable conditions increase significantly. A good example is Ebola epidemic in 2014-2015, the countries in the West Africa. At that time, mortalities from this preventable and treatable diseases like measles, HIV/AIDS, tuberculosis, and malaria has increased significantly, and it has superseded the impact of the actual epidemics, the Ebola, for which those the panic and the response were so. While people are concentrating on that, and to prevent such kind of situations, WHO advised to countries to select some essential health services which should be protected and maintained during such time of natural or man-made or other disasters. And some of the essential services which WHO mentions includes RMNCH, mental health, infectious diseases like HIV, tuberculosis, and so on. So RMNCH is put as one of the essential services which should be maintained. So as you know, the first case of COVID-19 was detected in Ethiopia in March 13, 2020. And there was an observation among healthcare providers and other stakeholders that the RMNCH caseload is decreasing in all service areas, including ANC, labor and delivery, immunization, postnatal care, and so on. And it's different reasons were given for that. So we conducted an assessment of the service flow in May 2020, in Gumbut 2012, to assess the extent of the impact of the COVID-19 on RMNCH service utilization. And to give you some perspective of timelines in those 2 months which we are studying, after the first case was detected in March 30, schools were closed March 16, and March 25, most of the federal employees were advised to work from home as much as possible. And on March 31, interregional public transports were suspended in some of the regions, especially for us. Oromia was relevant because our hospital and catchment health centers are accept many cases or patients from the neighboring Oromia region. And in April 12, the state of emergency was declared, and in April 16, cross-country transport, the public transport resumed, but it was made to be at half of the capacity of the loads of the transports. And this has implication in resulting in shortage of transportation, and the cost of transportation has increased also by 50 to 100%, which can have significant potential impact on accessibility for some poor patients. Next slide. So with the objective of assessing the trend of maternal and reproductive health utilization, health utilization before and after the reporting of the first COVID case, and to describe the provider's view of the impact of COVID-19 on maternal and reproductive health utilization, we conducted a mixed method study, both quantitative and qualitative one. So the study setting was at St. Paul's Hospital, which all of you know, it's one of the tertiary hospitals which has more than which has 3,000 and above women attending antenatal care annually, and more than 10,000 deliveries annually. And it has a dedicated RH clinic, which is called MICHU, which gives a comprehensive reproductive health service. And the hospital has 60 catchment health centers, but for this study, we selected 7 high-volume health centers to be representative of the 3 sub-cities in which they are located. So this is the name of the health centers which are included. So for the quantitative part, what we did was we collected from the HMIS registries at the different service outlets number of service acceptors or utilizers which are seen, and we have done this using a data extraction template, and we collected a 25 months data starting from April 2018 to April 2020 to see if there is a contribution of seasonal variations for the for the trend of the RMN set utilization. Then we compare the utilization over the 2 months after the COVID detection with the preceding 2 months immediately before that. That means Magabit and Miyaza with and Ekatit 2012, and we compare the 2 months utilization again with the same time in the previous year. So that was what we did. So the data extraction was carried out by trained midwife for trained. So these are the service utilization areas from which we collected the data: antenatal care, delivery, postnatal care, immunization, abortion services, post-safe abortion, and post-abortion care, family planning, and the sexual assault service utilization. Next. So for the qualitative data, we conducted an in-depth interview with 15 in-depth interviews were done with healthcare providers from these service outlets, from the hospital and the selected 3 health centers, and also from main stage focal persons at the sub-cities, and urban health extension workers were interviewed. So when you see the results in comparison of the 2 months data, as I mentioned earlier, almost all RMN service utilization has decreased significantly, and but the extent to which this utilization was affected varies by the type of services. And to see some of them, when you see the antenatal care, new antenatal care attendees, when you see the total of the hospital and the health centers together, has decreased by 28%. And the decrement in the new antenatal care attendees was very much different between the health centers and the hospital. If it is a St. Paul's Hospital new antenatal care attendees, the decrement was quite dramatic. While in the health centers, it has decreased, but it's not as significant as the hospital. And this might be the big fear that going to bigger institutions or bigger hospitals where, as mentioned in the morning, overcrowding is expected, and people think that there is higher risk of contracting COVID while they are visiting the hospitals. The repeat antenatal care decrement is also there, but it is not as high as the new antenatal care acceptors. Next one. So when you see the total, the deliveries, the decrement in the deliveries was there, but it's not as significant as other RMNSH service. We see it in relative terms. So the total deliveries both in the hospital and the health centers, when it's summed up, has decreased by 7% from the 2 months preceding the COVID. The 2 months after COVID has decreased by 7% as compared to the earlier 2 months. And when you compare it with the previous year, even it has a slight increment, 4.04%. And the increment is mainly overall its contribution of the hospital, which has resulted in an increment of the total deliveries. And this might be due to the hospital is serving as, or there are many feeding centers for the hospital. It's a referral hospital. And most of the service at the different peripheral smaller units has been disrupted because of the fear, and the referral rate might have increased and has resulted in the dilution of the total decrement in the total deliveries by that increment in the hospital. So we try to see just the stillbirths as a proxy of if there is an impact on the outcome of the services because of this pandemic. And what we have seen is the total number of stillbirths, some was at the hospital and the health centers, was 72, and it has increased from the previous months and also the previous year. But to see this stillbirths, the more accurate way would be to see the percentage or per 1,000 stillbirth rates, because the fact that it has increased the number of stillbirths, but this is on the face of the slightly decreased total number of deliveries. So we have calculated to the stillbirth rate per 1,000, and it was 27.17 per 1,000 deliveries after the COVID was detected, and this has increased by around 23%. It was around 22 per 1,000 pre-COVID 2 months. So there was a significant 23% increment in the rate of stillbirths, and this might be it needs further exploration. But one potential explanation might be mothers may be getting late in labor or with other obstetric problems in reaching to health facilities. And this has been seen in other studies also. In Nepal, they have assessed a countrywide data from their database, and it was published in Lancet, and they have shown that the stillbirth rate after COVID has increased from 14.14 per 1,000 to 21 per 1,000, and there was a very more dramatic and significant increment in this in that study also. So this gives us a hint that further exploration of the type of the case and what is behind each of these stillbirths might give us more clue. We try to assess the maternal days, but the maternal days were very few, 2, 1, and 2 in this specific time range. So it was very difficult to make a meaningful comparison. So I haven't presented that. The postnatal care again has shown a significant decrement. It has decreased by around 30%. We lumped any postnatal visit, be it the 6th day or the 6th week or any of the visits, and we compared them with the preceding 2 months in the preceding year, and it has shown again a significant decrement of by around 1/3. And when you see the family planning services, both new family planning and repeat family planning acceptance has decreased, but it was more pronounced around 42.8% as compared in the new family planning utilization as compared to the repeat one. And when you see the short-acting and the long-acting family planning methods again summed up together, both has shown a significant decrement, but the decrement is more pronounced in the long-acting reversible contraceptive. It was 42% decrement, while in the short-acting is 33%. So one explanation for this might be one thing which we have got from the qualitative study is that health providers has said that they were trying that panic phase of the pandemic. They were trying to minimize the contact time with their clients, and they have said that even the counseling and the care as much as possible, they want to decrease their time. And these long-acting reversible contraceptives like the implants and the others, it needs longer time during the procedure and the counseling. Overall, it takes a longer time as compared to the short-acting. So there might be a tendency to avoid the long-acting contraceptive, which have shown that there might be the reason for the disproportionate decrement in the long-acting contraceptives. But overall, the family planning utilization has decreased by more than 1/3. Okay, next. So again, the safe abortion and the post-abortion care are a similar decrement of around close to 40%, 38 and 37, and this is also one of the services which was significantly impacted, in which we have seen is marketing decrement. Next one. So in the sexual assault case, when you see the sexual assault, this service is provided mainly in the hospital at the Metro Clinic. So the post-COVID, over the 2 months after the COVID, it was only 8 cases which were seen at that period. And the previous months, it was 39 and 43, as you will see. So there was a sharp decline, and percentage-wise, if you see it, it is around 80%, but you can see it is a very marked decrement. And this, we have to remember is that during this period, what was reported and with various formal and informal means was that the rate of gender-based violence, sexual assault, and so on has increased dramatically, but because of people staying at home, and that might contribute for that. But despite that, the number of sexual assault cases which we are seeing has decreased. And in the qualitative part, they have told us that this might be due to mainly related with the access and the transportation, and I'll present one of the providers has said. Okay. So the immunization services has also decreased. It's not as dramatic as abortion and the family planning, but there was around 15% decrement both from the previous 2 months and the last year same period. And the qualitative data, we have collected different information about their preparedness of the health system and so on. But for this one, in the interest of time, I'm going to present only the reasons for the decrement of the different services, which was described by the healthcare providers and the other key informants which we have interviewed. I have mentioned different reasons for this decrement. The first one is the health facility policies. In the health facility policies, what we have found was that the different health facilities responded differently. There was no uniform direction from the initial phase of the pandemic from the ministry or the regional health bureaus. So this has resulted in varied response. For example, in the hospital, the respondent, the provider has mentioned that previously they used to see around 200 cases per day, but they have limited the number of antenatal case clients to be seen to 50. So they are returning back the excess ones to be seen in subsequent days, and this might have contributed to the lower number of cases to be seen. And they have also devised other things like scheduling change for the low-risk mothers and so on. And so in the previous one, the health facilities, most of the health centers have said that they haven't put a policy like the hospital want to decrease the number of cases to be seen per day, but they have designed like a change in the shift of the patients they see in the morning and the afternoon, and so on. It differs from facility to facility, showing that the lack of uniform direction. The other reason they have given was that fear of contracting COVID at health facilities. One of the health extension workers, urban health extension workers, mentioned that while interacting with her clients, she has seen that people, even if they were had a significant illness, they were afraid to visit health facilities and health centers, and they tend to stay back even if they have some reason to go to the health facilities. And a misconception about whether the health facilities were providing service or not was also mentioned by one of the respondents who was working in the Gulf Health Center in the EPI Center. In the end of the 2 months, the case has started increasing, and people have started coming for immunization. And she said that when we asked them why they didn't come in the previous their scheduled time, they thought that health facilities were closed and they are not providing this essential services. So there was some misconceptions also has contributed for this increment. And the other reason which was mentioned at that time was the lack of transportation. So the lack of transportation can be, it has different facets. One is the fact that there is shortage of transportation because of half-seated policy, and the other one is the cost of the transportation has increased. So one of the providers, Mutua, said that the case of some of the cases of sexual assault and others which are in the lower socioeconomic status, including housemaids and so on, are unable to come because of these barriers, including the cost and the shortage. And the other one is this lack of transportation. As I said earlier, most of the clients for these health centers are from the neighboring, the peri-urban Oromia region. So in Addis Ababa Health Center, they said, for example, a majority of our clients are from Sululta, and the road roadblocks, the road lockdown rather, has resulted in a number of mothers coming to their facilities, and they have seen similar trends when there were roadblocks due to security issues previously. So they are saying that they are seeing that the same pattern during that time, and their facilities were almost empty in the immediate days of after COVID. So there was in conclusion, there was a significant decline in the RMN stage client flow in the first weeks or the 2 months after the detection of the first COVID-19 case. In family planning, abortion care, and sexual assault case were the ones which were dramatically, significantly affected as compared to the others. The delivery service is affected, but it's not to a larger level as compared to the other ones. And they have given the various reasons which I've mentioned for the decline. And these factors might have impacted the outcome of the services, like the stillbirth rate, which we have seen. And this gives us a clue to do more studies, like seeing the trends of the neonatal morbidity or the maternal deaths. Even it should be done at a larger extent to get reasonable numbers in multiple facilities, but seeing those kind of patterns is important. And in the initial phase, there was no clear direction as to how the facilities should respond to the pandemic and its haphazard, and different type of responses were seen. And we have seen that these essential services are vulnerable for the various pandemics or similar type of effects. And as a recommendation, emergency preparedness measures of resilience should be put in place, because it is a very good experience and a learning opportunity, this COVID pandemic. And the Ministry of Health has prepared this implementation guide for non-COVID essential health services, which is a move which should be commended. And they have done also a massive media and communication campaigns after the notice of this significant decrement rates. And they are preparing self-care guideline, which is on process, and a telemedicine guideline has been launched by the Medical Service Directorate, and in general, such kind of interventions would help in the future. If there are similar instances, they might minimize the impact of such problems. And close monitoring of the RMN service uptake, which they are doing, should be continued till the end of this pandemic, and preparing a more comprehensive guideline for future similar situations. It can be a similar type of pandemics, epidemics, or man-made or natural disasters, a comprehensive one, how to protect and maintain such essential services should be prepared using this one as a lesson. And studies to assess the impact of the different outcomes, like the rate of unintended pregnancy or the maternal days, neonatal days, and so on, should be done in a larger scale so that we can learn from it, and it can help for future interventions. This is all my presentation. Thank you.
Thank you very much, those presenters. Would you come to the front for that? So to keep in time, we will only accept 4 questions for the presenters, and maybe a couple of questions from online audiences, if there are any. Questions for the presenters? Okay, Dr. Wondimu.
My question is for Zebenay. So your definition of status in the original. Did you look into like a data analysis or interpretation, whether that level of stress or depression was reflected in the form of compassion fatigue or abuse, patient abuse? Have you tried to explore that in your study?
Thank you very much. So my question is also to Zebenay. In the OBGYN department. So how was the sample size calculated? Is one. Other, most of the samples were from emergency OPD and labor ward. So now this is basically stressful area. And in the OBGYN department, we have different working sites, like antenatal care, OPD, wards, specialty clinics, and so on. So that this sample really represent the workforce in the department of OBGYN. Thank you.
Thank you.
Thank you. My question is to Zebenay. On comparing your findings to other researchers, you said most of the research used others similar skills to assess depression. That's in particular study used different skills than others, so you are difficult in comparing the findings. While from the outset, why did you choose the skills which have been used by others most common? And maybe sort of very important way, how did you assess the negative emotional response? And for Dr. Bekele, there is you try to explain it, but I didn't understand. There is a contradictory issue. There is a decrement in the number of cases in the hospital since COVID, in comparison to 2 months before and 2 months after the COVID outbreak, but there is an increase in the number of daily cases. So the case has decreased, but the number of illness has increased. Do you have explanation for this?
One more question.
No, I mean, my question is very simple for Zebenay. So why enjoy? I know you have your own reason, but for me, I was trying to, ask myself why Zebenay was not interested in people handling symptomatic COVID cases, because the most stressful sport for me is those professionals, dealing day-to-day COVID cases. So this is just a simple question: why you were very interested to see the stress of COVID? The second question is Delaynu. I think that looking at the service volume, quality in sample, we have some bias limitation because the sample is usually the frontline responder. Always, whenever there is like nationwide epidemics or whatever. If you remember, sample was selected at the first teaching hospital, or the first referral hospital to respond to COVID related problems. So I think it's expected that services will dwindle, both from the supply and demand side reasons. But from my point of view, mainly from supply point of view. So why don't you try to compare other teaching hospitals to avoid some of the biases attached to the same? Thank you.
Thank you. We have one question from online audience for Mr. Zebenay. The question is: did you consider the study period when you compare the major factors of contributing to other studies that may affect the difference of the study? So, looking at the number of questions, I will give the first chance for intervention to respond.
Okay, there are a lot of questions which were forwarded for me. I will start for the first question. Have you seen whether there are patient abuses or client abuses or not because of depression? I have reviewed some articles which are published, and actually I haven't specifically seen some patient abuses or like compassion fatigues because of depression. Rather, there are some termination of their jobs because of depression, because of like fear of acquiring the virus. There are some termination of their jobs, especially some. But in our setup, I haven't seen this one. How the sample size was calculated, as I've said in the introduction, this is part of a large study, and we generally studied the psychosocial impact of COVID among healthcare providers. We included both gynecops clinicians as well as frontline healthcare providers, and the finding is the frontline healthcare providers, the depression is around 89%, which I didn't present here. But in the gynecops department, it's around, as you have seen, 64.7. So the sample size, we did actually a comparative study. So this is part of that study. We did a comparative study, and this is subgroup analysis from the larger study. So it may not represent the total, that means the source population, because the source population is very large. That means the clinicians are too much in St. Paul, so may not represent because of like the occasion. We simply calculate what we get. Even there were a lot of non-response rates, so we simply calculated from what we get from the respondents. So and I put it in the limitation part. In the original paper, I put it in the limitation part. The other, why don't you use the patient, the other scale? Actually, there was a mental health specialist in our study, and he chose the hardest scale to assess the level of depression. So probably if we did a review prior to the study, we may correct this one, but in mental health, there are different scales. So we simply choose the hard scale and we did it. We didn't have any other reason. The other negative emotional study, we did factor analysis or we did principal component analysis. There are some questions about emotional response towards stress. So we did the factor analysis and based on the eigenvalue, we classify based on that, and we classify as if based on the factor or the principal component analysis, negative and positive emotional response based on that analysis. The other, why you are interested in OBGAI? Actually, our interest was to suggest something about how the sexual and reproductive health services are affected because of fear of the virus, things like that, because of mental health problems of the professionals. And we compare it from those who directly involved to the care and these professionals, and whether they reported in the other study. A study period doesn't have any effect on the factors. I didn't see this part. We didn't consider the study period, whether they have significant effect on the mental health problem of study subjects or not.
Okay, thank you very much, Mr. Zebenay. Dr. Slider, you have a couple of questions.
Okay. Mine are short ones. The first one from Dr. Abel, I think the slides are confusing, sorry. So the number of deliveries, when they are compared from the preceding 2 months, has decreased, both at the hospital and at the health centers, and the sum. The one which has shown increment is when we compare it with the same time last year, it has slightly increased when you compare it to that one, showing that the deliveries were not impacted as markedly as the other ones. Otherwise, that positive rate is for comparison with the last year, and decrement is with the preceding 2 months. So, but it has decreased more in the health centers, and the decrement in the hospital was very small one, almost was flat. And the other one is Dr. Mangus's question. Could it be a biased one? By the time we are collecting this data in Sunny 2012, St. Paul's was not selected as a treatment center as an information. At that time, it was only the hospital was only coordinating the Millennium COVID Centers preparation. So it was not one of the treatment centers. So, but even with that, it might not be representative of what's happening in the country, especially in the there are anecdotal information that those who are in the rural part have been impacted more, even severe than the urban ones. But it is going to be more for the hospital and the catchment care centers for our consumption, and it might not be necessarily representative of what's happening in the country. But regarding the COVID one at that time, that was not a factor because it was not selected as treatment center at that time.
Okay, thank you very much. Even though we just had COVID, which is the international announcement in the first case in Ethiopia, still the health system have been shocked when we announced the first case. And these two studies replaced in that shock. In the first study, it's a reminder that care for the caregivers should be a package of any health service, especially mental health care. Should be, part of component of any health care provision. And in the second presentation, we have seen that when we think about emergency in the health system, factors beyond the health care are also important. And we have to think about holistic approach and so on. So we have picked good lessons for next emergencies that may happen both in Ethiopia and elsewhere. So thank you both presenters. It was a very informative presentation.
Good afternoon, morning, and good evening. So we have to our presentations by Mr. Wondimu Chirfa and Mersha, and I will introduce Mr. Wondimu Chirfa. He has 50 years of experience at monitoring, evaluation, and designing appraisal at the gender health in Ethiopia. His main focus on sexual and reproductive health, that which is he has his master economics. He is presenting on project intervention to improving sexual and reproductive health outcomes of adolescents and youth and experience of sexual and reproductive health service provision in Afar before and during COVID-19 pandemic. Our second presenter is Teshager Mersha. He has also about 50 years of experience in research, training, consultancy, and teaching in project monitoring, evaluation, etc. And the main focus on sexual and reproductive health. He's a research advisor at Ministry of International. He's supervised a lot of researchers and is currently engaged in a lot of projects in supply side barriers, adolescents, weekend evaluation, and the like. So the first presenter is here. For the second presenter, I will Teshager. So we display a recorded view, and he will be available on the question and the question and answer sessions. So since you are running out of time, we will stick to the presentation 50 minutes. So I will call upon Mr. Wondimu for the first presentation. Thank you.
Thank you very much. My name is Wondimu. I'm from Engender Health. Just to briefly introduce you about Engender Health. Engender Health is international NGO working among more than 100 organizations in the world and have more than 75 years of experience globally, and in Ethiopia about 30 years. And we have been working on this service for almost throughout the country. This is briefly to introduce Engender Health. Please, next slide. For this, I need to update you on the corona pandemic. This is the old version, I think, the one I shared with lately today. Thank you very much. This is the COVID-19 update till today. I think globally it is cases are about 53 million. This is about 1.3, which is 2.45. Recovery is 13 million. Africa is 1.9. Total case so far till today is 1.9. This is about 46 million. The recovery is 1.6, which is 84% in our country. Till today is 101,000. The death is about 1,554, which is 1.53. And the recovery is about 63,000. Source for this is the Worldometer. Is to update the COVID-19 pandemic. As this is the project abstract, I need to just briefly present the objective. Objective one is about demand creation among out-of-school youth and school youth in the community. Second objective is on quality services, which includes early and forced child marriage and LGBT counseling. This also focuses on quality service provision, capacity building of service providers, just implementing quality improvement initiatives, and lastly on medical infrastructures and supplies of equipment and supplies. The last objective. Coming back, please. So the last one is enabling environment. Yes, work on enabling environment where objective one and objective two can be successfully implemented. Please next slide. So before just starting implementation of this project in 2017, we have tried to conduct a baseline survey in community as household survey among facilities and schools. So these are some of the baseline findings we have done before implementing this project. The current use of family planning for pills was 99.5, for injectables 53%, for implants 11%. As it is the least family planning method uptake in the region when we have tried to conduct the baseline survey. When we come to some of the more components, NC4 was about 38%, skill delivery was 20.7%, and postnatal care was 12.6%. This is based on these baselines that we have tried to develop our plans and implement this as a service implementation in the region. Please next slide. So this is services under consideration to develop these abstracts before the pandemic and during the pandemic. Family planning service uptake was about 4,070 during January to March, and during the midst of the COVID is about 3,466, and this decreased as a result of the pandemic by 17%, with mere number 604. Abortion care was 339, and it decreased to 224, which is mean number 115 or 51%. BMOC was 6,897, and it decreased to 6,376, and it decreased by 8%. Totally, the cumulative of all these services were declined to 1,240, which is a decrease in 35%. This next slide. So these two link this. If you see all of the services, it started declining in the month of April, or the family planning, CAP, and BMOC were decreasing in April, which links to the prevalence of or the new cases of the COVID-19, which was 149 in March, but dramatically increased to 1,932 in April. So as my colleagues were presenting, the panic, the fear, and everything is affected the service provision of all these things, which is directly linked during the month of April, which dramatically increased from March to April by March number, and this increased in June to 8,772, and increased much higher to 70,000 cases in June. So all these services, just the point where all the services declined is linked to the month of April, where the cases were very high. This next slide. Same is true. This also on the month of April, just ANC1, ANC4 skill delivery just declined in the month of April. This next slide. So the method we have tried to use was data on this slide from DHS database, and the clean descriptive analyzed, and quarter before COVID-19, as I tried to say before, January to March and midst of COVID-19, April to June was analyzed to make brief comparison. And the comprehensive contraception abortion care BMOC was major services just taken into consideration to analyze whether just this COVID-19 had impact on the service provision of this was. Additionally, comparison of client service uptake in the month of June against April was against the month of May was area of analysis to see the service uptake is upward sloping or downward sloping. So major findings was short-acting family planning, long-acting reversible contraceptives. Comprehensive abortion services have started increasing during the month of June 20 when we compare against May 20 by 10% for short-acting, 30% for LARC, and 3% for comprehensive abortion care. Similarly, BMOT was also starting increasing by 17% in the month of June when we compare against the month of May. Is next. So what we have done to overcome the COVID-19 challenges? One is science-based monitoring and reporting done IPFS, done just individually contacting service providers. We're conducting just individual provider follow-up and support every month, rather than doing this, which is time-taking and more riskful activity for the contraction of the virus. We just focused on science-based monitoring and reporting. A virtual meeting was another approach through which we try to sustain all services by supporting facilities and providers. Just integrated COVID-19 and so SRA social mobilization through mobile vans. We're just using the marketplace campaigns and the like before COVID. Now that's as long as that is a risk for activity, we avoided that and we used mobile vans by integrating just awareness creation activities of COVID-19 and SRH. Structured on-job training. This we were just taking providers to somewhere to provide services, trainings. Now, in contrast to that, just to sustain services, we have just trained providers on their job, just right on their job through trained course. We were also replanned some activities which are less risky to the COVID-19. So we just avoided such review meetings, marketplace campaigns, social mobilization, every activities which takes into consideration gathering of people were avoided, and we focused on less riskful activities. Demand creations were also made through local radio programs in the region with local language, so that demand creation activities will not be seized as a result of COVID-19. So we also just tried to work on ecosystem mobile platform. Yes, we just have been sending COVID-19 information to clients so that they can get information and do not panic or do not fear to come to facilities to utilize services. There are major just issues or major innovative approach just we have done to just increase services that have been just started declining in May. That's why I have just tried to present earlier. This next slide. Just in the previous slide, I have tried to show that services were declined, and that's from March to April. Some of the reasons are dedication of facilities to serve as COVID isolation centers. They have just stopped providing services and concentrated on serving as isolation centers for COVID-19. Assigning trained providers to create awareness rather than just providing a service was another reason we expect. Clients' fear of infection during visits to facilities. Even there are some areas which requested us to provide outreach services than just visiting facilities by their own to utilize services. So those are another reason. Assigning diversity of government resources and priorities. Every attention, activities, resources were just diverted toward this preventing the pandemic. Suspension of trainings, review meetings are another reason for decrease in service uptake, because that's the platform through which just we replan, we improve our performances. and demand creations activities, which I just tried to present in the first slide on objective 1, which is just demand creation among in-school users, out-of-school users, community level demand creation activities were completely just decreased. This was the expected reasons for decrease in service uptake. This next slide. So we conclude that program implementers like us need to be innovative in crisis situations like COVID-19 to sustain service provisions rather than panic, so that clients' right to have access to such services will not be compromising. This next. So I'm grateful to acknowledge our partners working with us on SRH service provision in the region. Amref Health Africa, which just works on demand creation activities at community level. Triggerize, which work with us with mobile platform to facilitate clients' referral from community to health posts. Philips Health Initiative, which just distributed very sophisticated medical equipment to health post health centers and the community to provide DMOP and other services. And after is Afar Development Association, which works with grassroots community to create demand. So I'm grateful to acknowledge all these partners. This is all my presentation. Thank you very much.
Thank you, Mr. Wondimu, for your excellent presentation. I think we'll have a video for the second presentation and we'll have and answers after that. Thank you.
Okay, my presentation is on sexual and reproductive health. Service during COVID-19, and specifically this a summary of countries' response. This is just a documentations of learning from Maristops International and International Parenthood Federation affiliated organizations. So experience related to SRH during COVID-19 is the title of my presentation. My name is Teshager Mersha. I am working for Maristops International Ethiopia as a research advisor. Just to give you a brief introduction on a slide, we all know that COVID-19 pandemic is dramatic, and the programmatic landscape of SRH care. In fact, all healthcare services has been impacted as a result of the COVID-19 pandemic. Service delivery has been, the capacity of service delivery has been challenged. Frontline service delivery capacity has been threatened since March 2020, right after the declarations of the global pandemic. SRH care providers evolve its service delivery models to respond. So according to the change and the dramatic impact of COVID, service providers are trying to deliver the services in terms of by adapting to the situation that has been created. So understanding this response, documenting the lessons and the experiences are essential. So experiences and lessons which has been exercised somewhere else could also be applied in another area. That is why we need to document those evidences to make sure that we are not learning from our failure. And the purpose of this presentation is just to summarize what are the COVID-19 response based on the two non-governmental organizations. These two non-governmental organizations, which is MSI and IPPF affiliated programs, which is the leading SRH service providers. So we're trying to examine, trying to summarize the experience of 20 countries working with MSI and IPPF affiliated programs So countries were selected purposefully to make sure that lessons are relevant to our countries. So this information has been gathered. Being I am working for MSI, I have the opportunity to see situational analysis reports. I am also engaged in some different working groups. There are internal communications which is move around, and based on the web searching, I am trying to summarize what are the experiences elsewhere within these two countries which are affiliated to MSI and IPPF. And this is a summary of findings based on a qualitative analysis. And just to also to give you, a context of the impact of COVID. The impact of COVID is clearly seen in SRH service provision, like increased barriers to provide services. Some of the in some countries, clinics were closed. In some countries, clinics were closed due to strict lockdown. Like, for instance, in my review, I came to know that Bangladesh, Zimbabwe, so does Palestinian, they have closing their duty. Clinics were closed due to a strict lockdown, and in some cases, operating hours has been reduced. And some other countries, there is an impact of COVID, which has been explained in terms of increasing barriers to accessing self-services, which is related to the quarantine, self-isolation. In some cases, there are school-based programs as a result of school closures. So this also has been creating some difficulties in accessing school adolescents in their school, travel bans and border closing, this economic insecurity of clients in accessing self-services. This also has affected supply chain failures. Shortage of abortion medication and contraception has been observed in the countries under review. We also know that manufacturing, some of them have been shut down because of, they are unable to operate during COVID. So in some cases, those who are manufacturing, there is also an important delay of contraceptive commodities and safe abortion medications. So there is effect on the supply side, and this also aggravated as a result of the demand for PPE. So this has been seen in terms of impact and supply. There is also a strained health system leading to lower access, which is a shortage of healthcare providers, increasing waiting time, diversion of funds from something which is critical, SRH programs to the other. The other impact which has been clearly seen is as a result of impact of COVID. Now and then it has been said that gender-based violence has been increasing. Unplanned pregnancy has also increases, and intended pregnancy is increasing due to inability to access to contraception, and in fact, incidents of sexual violence due to economic insecurity. So health concern become a secondary issue. This has been the major impacts of COVID, which has been, there are actually some specific impact which has been seen in some country programs, like some of the delivery channel, which requires a frequent mobility, like the mobile outreach program to deliver free contraceptions in a remote, rural, and underserved urban location. The outreach program is found to be less feasible during COVID. So it was needed to redefine the outreach model because of COVID. In some cases, as a result of COVID, choices has been limited. There are cases, delivery of permanents and long-acting contraceptives has been stopped in some places, and providers as well as clients prefer some of the methods so as to avoid some infection. And the pandemic is also affecting provisions of technical assistance by international organizations to the public sector. So private-public partnership has been also affected as a result of COVID. There is also, I mean, in most of the reviewed country programs, there is a measurable reduction in client flow. We have also observed a decline in client numbers across all channels due to inaccessibility. And the other thing, I mean, at the earlier stage of COVID, there is also a high level of community stigma towards the providers, which is health providers has been stigmatized. And this is also some of the impacts of COVID. What are the responses? Some of them are trying to make rapid adaptations towards physical distancing, introductions of appointment system, and arranging additional waiting rooms and places, so as to make sure that the necessary physical distance has been maintained. And in some cases, there is an enhanced reinforcing infection prevention measures. This has been also strengthened and reinforced compared to the pre-COVID period. Repurposing the community engagements or health promotion activities. Demand creation has been challenged as a result of COVID. So engagement of community engagement and health promotion activities to deliver accurate COVID-19 information and SRH information. So in addition to providing information related to SRH, this community engagement and health promotional activities also including COVID-related information. Using community radio, because face-to-face community engagement has been replaced by community radio and the use of social media. As a result of COVID, some country programs are trying to be more innovative in addressing, in providing the service, like applying telemedicine for medical abortion counseling and assessment. This has been applied in United Kingdom, Australia, and South Africa. So program innovation has been also made in response to COVID. Strengthening telephone follow-up. This also has been applied in Ghana. To some extent in Ethiopia, MSI program is trying to use call center as a to promote continuum of care through its call center. So strengthening telephone follow-up has been applied in like, as an example, Ghana, spread over promotional days to minimize crowds at facilities. And instead of gathering a large number of population for SRH promotion, family planning days, there are events which has been organized to promote services. So this has been spread over so as to minimize crowds at facilities. The use of social media and the digital media. This was also like using WhatsApp in promoting, in providing information on issues related to COVID as well as SRH information. This has been applied in Kenya, and the other responses which has been seen in Ghana is reinforcing the importance of hand hygiene. This is also a part of the activity which has been promoted across in our health system. At the beginning, as a result of the supply chain, the shortage of supplies in sanitizing agents, there is, in Kenya and Ghana, do yourself having. This was also at a program level. This has been also applied. Post-abortion clients in Madagascar, they have been they are arranging transport in public, using public transport during the pandemic is found to be difficult, and as a result, some programs are trying to arrange logistics to make sure that clients are come to the facilities and go back to their home. And in almost all programs, what has been applied is supporting the providers in the field to get the necessary personal protection equipment. The other one is, guidelines, quality standards. This is a continuous training has been tried to be given by this organization to the providers. So clinical trainings and guidelines, refresher trainings has been given face-to-face before COVID. But now, due to the changing circumstances, this has been changed into providing training using a technological platform. This has been also applied as a virtual training on guidelines and quality standards. Like as I said before, the adherence to infection control, so infection control measures in all venues and services have been adhered. And some countries are trying to, instead of saying some, most of the countries are developing a contingency plan. They listed down the key risks which has been created as a result of COVID in accessing quality SRH service. And they are trying to prioritize the risk based on their impact and in fact, in relation to the resources they have had. And they are creating the resources they have had. And they are creating a separate plan that outlines the actions they need to take care. So based on that, they have been trying to develop an adherence, a contingency plan. And in some cases, there are some programs are trying to embark on self-care opportunities, using call centers to strengthen client care. Like as I said before, in order to promote a continuum of care, the call center's contribution has been found to be important during COVID. And targeting vulnerable groups and integrating SRH into emergency response. These are some of the responses which has been applied during COVID. Some of them are trying to use, major and skeleton staffs to have a materials and continue to offer services in Togo in a situation where we are unable to mobilize all providers. And if you feel unsafe to provide service by mobilizing all the providers, some of the health providers are trying to be on board and some are laid off. So allowing skeleton staffs to have the materials and strategies during a shortage of personal protection equipment has been applied in Togo. Promoting self-injectable compound, using SMS technology, using call centers for urgent consultation has been applied in Morocco. And in Iran, like for instance, providing online counseling. Educational training has been used through, and instead of face-to-face, they are using online educational training. And not only about contraceptives, they are also imparting information related to COVID. Like I said before, Palestinian has been closing down their service at the beginning, and they are trying to restrict themselves in providing only psychosocial support through mobile telephone lines. So in general, countries have different mechanisms in response to COVID. Some are trying to use technological appliances and platforms to make sure that they are accessing their clients and giving some of the components of the service instead of using face-to-face. Some are trying to use different types of demand creation activities by creating a situation where a number and client flow decrease. So what are the major learnings that we have had from all these responses? We came to know that actually, the global health system has a lot of learning on how to provide SRH services during the pandemic. Experiences in Zika, experience in Ebola, trying to say that as long as we are supporting our providers well, SRH service can be delivered. This is a learning that we can. So as much as we are providing supports to the provider, so that we can, it is possible at least to provide a minimum requirement of SRH service to the clients. And we also need to actually deal with fear. At the beginning, instead of relying on I mean, at the beginning of COVID, we don't have a lot of evidences on how, how COVID can, how we can respond. How COVID can, how we can respond to COVID. And we don't have a strategic readiness and actually practical needs. The way that we address practical needs are not clearly known at the beginning. So fear comes at the beginning. So it was important to treat those fear at the beginning and develop a trust among health, trust among clients towards to the health service. And in fact, the health system has to also address not only on the provision of the service, it is important to address the issues of quarantine, transport restrictions. There are also financial concerns, which is related to the COVID, and there are economic troubles, which has been a result of COVID. These are issues which has to be addressed in order to fully actually respond to the pandemic and the service, SRH services. SRH services, when considering SRH needs, when patients are being investigated or treated for COVID or pregnancies, HIVs and contraception, these are, we are expected to integrate the pandemic with the other basic health services so as to provide the service fully. There are outreach programs which is found to be more suitable during COVID in order to deliver services and messaging. In a situation where clients are unable to come to the facilities, by providing the necessary equipment for protection to the support providers, it is possible to provide services using an outreach model with all the limitations, I can say. In some other countries, it was providing services in a conventional way was found to be difficult, especially to reach vulnerable groups. So in a situation where technological capabilities is possible, there are cases that telehealth has been applied in reaching vulnerable groups. In our situation, we can think of that pharmacies has been a good venue in providing service, in providing SRH communities. There are issues of community stockouts at any time, but in a situation where there is pandemic, community stockout is one of the issue which has to be responded responsibly. The responsiveness of addressing the community stockout is a major issue at this time. And there are also political, policy and legal restrictions, like in our cases, using. So in general, it is possible to. We learn that it's possible to provide services during COVID by understanding that there are a part of a community which requires a special attention. Like there are people who are in need. So addressing this part of the community has to be given special attention. And in fact, there are cases we can use a technological approaches to go along with the situations of COVID in general. Thank you very much.
Mr. Wondimu and Teshager. So in the first presentation, okay, we have seen the rapid decline of this sexual and reproductive health services, the onset of COVID from March to especially March to April, and revitalization of the importance, especially after June onwards, through a lot of interventions, including site-based mentoring, integration of sexual and reproductive health services with social mobilization, on-job training, and a lot of technological advances and yes. And also similarly in the second presentation, we have seen the impact of this COVID-19 on sexual and reproductive services, and at the same time, the country's different responses, and specifically with similar intervention in the first paper, particularly mail stops and the IPPF experience were reflected. So I hope, though we are running out of time, we can take some questions and answers. Okay, Dr. Langston, Abel, and okay.
Thank you. My question was to the presenter. Just on aggregating the data between CAG and BIM. I was trying to understand which components are included in the data and also in the tracking. To the best of my knowledge, signal applications or demo include design evacuation, particularly for the purpose of post-abortion care. So did you disaggregate the data between the two, or you just said CAG and BIM? Because I see a lot of overlap. Thank you.
Okay, Dr. Abel.
This our clients, the discussion of it. Good lesson to take it for if the lesson is there, we can perhaps this what is it?
We have initiatives from online. Till other questions come, we respond to the first question. I think questions are well prepared. The first is the remark. There are a lot of sub-signal functions, or depending on the center. Okay, so which components we disaggregate, which components were revitalized, and I think the second, okay, the question addressed for the online. Yeah, so we'll see the response.
Thank you very much. I think I have been asked which component we added in BMOC and CAG. Yeah, the CAG components are the safe abortion care and the post-abortion care that we included. And for BMOC, just we included this component of BMOC that we have been providing, that's ANC1 plus, ANC4 plus, skill delivery, postnatal are the services that we have been providing, and these are the components that we added. Sure.
So the antenatal data is in the BMOC?
Yeah, we added there.
Yeah, specific information. Some different functions, which affected and which are revitalized, have specific information. Mostly, the information is for Teshager.
Is it possible to repeat the question?
Yeah. On the lessons learned, there is a recommendation of lesson learned regarding all use of misoprostol and mifepristol. Misoprostol and mifepristol for early abortion. So which countries' experience is this, and is it applicable for our setup? Because we know that most of our clients, they don't know the gestational age, and if home use is allowed, is it applicable for?
Yeah, can I respond actually? Hello?
Go ahead.
Can I respond?
The question?
Hello?
You can respond.
Okay, thank you. Actually, the experience of second dose at home is not applicable in our country, but in most of the MSI program, we do have like 38 marriage stops program, and the number of programs under IPPF is like 106. So there are countries which are applying, having second dose at home. A particular example, I can say that this is applied in Bangladesh. They also have, in UK, it's possible to have second dose at home, and even it is possible to fetch all doses at even they can fetch it at pharmacies. So there are research and evidences actually to what extent it is safe to take second dose at home, but this is not actually possible from a regulatory and a regulatory purpose. From policy regulatory reason in our country. But this is, I know that this is a point of discussion among our policymakers. In the working groups, this is a point of discussion. Even MSI has also initiated a research project on to give evidence to the working groups, which is organized by the Ministry of Health, to what extent second dose at home is safe. And we are also documenting experiences from other countries. So I know that this is not going to be applied, but there are countries which are applying having a second dose at home.
On the question, it's good novel experience, but as you see, assessment of gestational is difficult. Most important experience that clinical assessment is missed. So probably that challenge should be strictly looked upon. And as you said, probably further researches before further implementation is important. Thank you.
Yeah.
Finished.
Sorry to shed light to the confusion about such things of methopustol and methopustol. We have been working with the Ministry of Health to introduce to the national health system. But as clearly said earlier, the challenge is the second dose of MEFE. But there are experiences out there. I'm sure most of you know that about the abortion on the web. In countries where abortion is strictly restricted, like Saudi Arabia, women are requesting MEFE and MISO through the web, and if they get adequate and continuous counseling support, they can take it. So it's a safest way of making MEFE accessible to women at large. So it is a kind of evolving science, and as I said earlier with Dr. Mesaret and Jamal, we are working on that to make it like a new phenomena for our health system very soon.
People working on CLR
That's right. We can see what the challenges in the clinical assessment is.
I think for our setup, the evidence is very clear. Single dose versus adding a second dose in terms of efficacy, in terms of avoiding ongoing pregnancy, and in terms of preventing complication is very clear. Okay, so adding a second dose will increase the efficacy and will prevent complications like having incomplete abortion. When it comes, the question comes, where are they going to take it? Is it at home, or do they have to be at the facility when they take the misoprostol? Okay, so if there are some programmatic data, we can extrapolate evidences, but so far there are only a few studies that looked at inpatient versus outpatient management of safe abortion. But there are strong evidences from programmatic data, and also, as you said, there is one, for example, Women on Web is a very well-known website where women get information about how to take the drug, and they don't even have to visit the health facility. They do gestational age assessment, everything by themselves, and they used to take they are taking the drugs at home by themselves. So when it comes to our setting, yes, we have to have the necessary chain of commands to make that into practice. And until the end of 2018, misoprostol was available on Amazon UK. Okay, they can just order it on Amazon and they can take it at home. Okay, but now that has changed again because of so many reasons. Thank you.
Thank you. We are running out of time, so we have interpreted a lot of sessions, and we have seen the impacts, the challenging impacts, and also the different novel country responses. So thank you for your attention, and thank you for all the presenters and for your excellent presentation, and the participants for your active participation. Thank you very much.
I think this momentum will continue for tomorrow. We will have similar interesting scientific sessions. We also have a state-of-art lecture. So for today, I will close the session by thanking everyone for the day.